Today I'm going to talk about my journey with the spirit. Before you start thinking that I'm a witch doctor, I'm not talking about that kind of a spirit. The spirit that I'm talking about is the one which you are going to go home today, pour into your glass, and have after a heavy day at TED. Like any other journeys, this journey also has lots of fellow travelers. And this story is not just about me. Sometimes it's more about these fellow travelers than about me. So I'm going to introduce you to the first fellow traveler. Her name is Sarika. She is someone my colleague sees in a clinic. Sarika is a defeated lady. She's broken. She's battered. She's battered physically. She's battered emotionally. She's scared. She's worried about her future. She's worried about the future of her children. But this story is not about Sarika. This story is about Rajan. Now, who is this Rajan? Rajan is Sarika's husband. Rajan drinks heavily, but not every day. He comes home drunk sometimes, gets angry with Sarika, beats her. He diverts money from essential home expenses to his drinking. He does not take good care of his children. But if you were to meet Rajan on the street, you wouldn't realize that there was anything wrong. He holds a job, does it pretty well. He wishes you if you see him on the street. He has a conversation with you. You would not think that there's anything wrong with Rajan. He is not the typical alcoholic that we think about when we say someone has alcohol problems. He is not the man who stumbles across the street at night, who falls in the gutter and sleeps there because he can't find his way back home after having his alcohol. He is not the person who wakes up in the morning and the first thing that he needs to do is have a drink. He is not that kind of a person. But that does not mean that he doesn't have a drinking problem. But then you would say, this is just one Rajan. Why are we worried? I mean, India does not have a problem with drinking. Well, numbers tell me otherwise. If we look at this pretty picture, what it essentially is showing us is the change in disability over the past 25 years in men when it comes to drinking alcohol. And what we see here is essentially in developed countries where the proportion of drinkers or male drinkers is more than in India, the disability due to alcohol is going down. Whereas in India, it has been progressively going up over 25 years. That's disability. Let's look at death, because that's a more harder statistic that you can't argue with. These are the numbers for death. Again, 25 years, the trend of deaths caused due to alcohol in men. What you see in India is that it's more than the developed countries. Again, in these developed countries, the proportion of drinkers is higher than in India, but the deaths in India have been progressively increasing over 25 years. In some developed countries, like Australia and New Zealand, the deaths are indeed going down. So we do have a problem. India has a serious problem with alcohol. It's just that we tend to push it under the carpet. It's just that we can't see people like Rajan because all the problems happen inside the house and not out there on the streets. But that's the problem. What do the policymakers want to do about it? The policymakers want to focus on those 4 alcoholics that I was talking about. So in this 100 men that you're seeing standing there are 4 men who have severe alcohol problems, and the government tends to focus on these 4 people. There are 20 men like Rajan in those 100 people whom no one is doing anything about. For those 4 men who have severe alcohol problems, what we have are these huge buildings or de-addiction centers where they are supposed to get treatments. Most of the times, these de-addiction centers are poorly funded poorly staffed, generally defunct, and if they are working in some places, they are geographically inaccessible to most of the population because they are sited in urban areas where a very small proportion of Indians live. More importantly, the whole idea of treatment of people with drinking problems in these de-addiction centers is predicated on the concept or on the idea that we'll have enough mental health professionals or mental health specialists who will deliver care for these people. Unfortunately, we don't have that number in India. For a population of 1.2 billion, we have at last count around 4,000 psychiatrists. And let's add psychologists and psychiatric social workers to that. Still, the number is not enough. So who then is going to deliver care for people like Rajan? I have stated the problem. I have told you how the existing solution is not good enough. But that's not my job to tell you that there's a problem. My job is to find a solution. And when conventional and traditional solutions don't work, we have to start thinking out of the box. We have to disrupt and shake the status quo. And how do we do that? It's easier said than done. If I were to say to you that given the opportunity, we can train each one of you here within a fairly short period of time to become frontline providers of care for people like Rajan, you will probably give me an indulgent smile because you don't want to offend me. But inside you're thinking, probably the shrink needs to see a shrink. Well, evidence. Meet another fellow traveler. This is Sunaina. Just like any one of you, she does not have any training as a mental health professional. We trained her within a short period of time to provide high quality, evidence-based psychosocial care for people like Rajan. Before we trained her, she did not have any qualification or degree in providing psychosocial interventions. Sunaina is not the only one. We have many more like her. And what are their backgrounds? Accountants, BPO workers, shopkeeper, housewives, just like any one of you. That's a big idea. You could turn around to me and say, well, nice idea, but where is the science? Finally, the modern contemporary world revolves on science. Where is the science? Where are the numbers? An idea is just not enough. Here are the numbers. Without going too much details into the science behind how we got these numbers, what we essentially did was to do a trial which compared delivering care for people like Rajan using people like Sunaina against current care in the system. This is what we found. If people like Rajan get care from people like Sunaina, they are more likely to remit from their drinking problems. That means that when we apply a standardized questionnaire, we find that after they receive intervention from Sunaina, they no longer have a drinking problem. We find that people like Rajan who get treatment from people like Sunaina are more likely to be abstinent as compared to those who don't get their care, as in they are not drinking anymore. We also find that people like Rajan, when they get treatment from people like Sunaina, are more likely to remain abstinent or not drink on more number of days as compared to people who don't get that kind of care. And this is science published in a high impact scientific journal. So now it's no longer an idea in our head. Now it's proven science. Well, you could still have more arguments. You could say, well, nice study, well done on publishing all of the results, but doing something like this in a clean, neat, sterile, scientific setting is easy. When you take this back and try to implement this in the real, messy world, it probably might not work, because the real world is not as clean and neat as your scientific world. Fair enough. We took the model to Vidarbha in Maharashtra, one of the most deprived areas of India. Drought-prone, farmer suicides. We took it to Vidarbha, and what we saw was that before we took the model to Vidarbha, around 4% of people with depression were getting any kind of treatment for their problems. We introduced the model, that number jumped up to 27%, a 6-time increase, which is massive if you look at it just statistically, but in terms of impact, it's a huge number. Where next? Because the applause now tells me that I just need to rest on our laurels and say, fine, you're done, the job is done. But I think the job is not done, because we have a long way to go to provide care for people like Rajan. This is just the beginning. And we choose not to rest on our laurels. So what do we do next? Technology. We are now going to try out 2 new things. One is what we call as telepsychiatry, where we use technology to provide care to people living in remote areas. So I could be sitting in one place in Goa, say Panjim, and I could deliver mental health services to someone sitting in Kankan. So they don't have to travel all the way to Panjim, because for them, traveling all the way to Panjim means time spent, money spent. We can save them the time and the money. The other thing that we're trying to do is use mobile phones to deliver interventions for people like Rajan. This does not need a human being now. There is an algorithm which will be built into the mobile software. When the person who has drinking problems feeds in their drinking history into the program, automatically the algorithm will generate a psychosocial intervention for the person with drinking problems. That's doing away with human resource needed, because we don't have enough human resource. That, we think, is going to be a force multiplier. So we're not trying to do away with lay health workers, or for that matter specialists. We're just trying to make life easier for them and increase access to care for people like Rajan. But that's another story for the next TED Talk, not for today. For today, I want you to listen to Manoj. He's going to encapsulate my whole TED Talk in a minute, which is an achievement. So let's listen to Manoj, who
जॉबाक आसतना ताच्या उपरांत सुद्दां सो ड्रिंक करतालो, सोरो पियेतालो. आनी सोरो पियेता हितून अशें जातालें की थोड्या क्वॉन्टिटीन पियेतालो, मागीर मागीर क्वॉन्टिटी वाडली. इतली वाडली ताच्या उपरांत मागीर हांव लग्न जालो. लगीन जावन थोडे दीस कमी केले. पूण परत फ्रेंड सर्कला भितर रावन म्हाका सोऱ्या कडेच वयचें अशें दिसलें आनी सोरो पियेतालो. लोक सुद्दां म्हाका जेन्ना पळयताले तेन्ना बेवडो कसो अशें रिस्पेक्ट दिनासले. तेंच्यांनी एक सांगलें म्हाका की तूं फ्रेंड सर्कल जेन्ना तुजे कडेन येता तेन्ना तूं तांकां मोगान प्रेमान अशें सांग. बाबा आयज ना रे, तूं मागीर तुमी बसा रे, हांव पूण कोल्ड ड्रिंक घेता, तुज्या वांगडा येता बसता पूण कोल्ड ड्रिंक घेता रे अशें सांग. हें करून इतलें सांगलें न्ही. पूण म्हाका तेंच्यांनी कितें वखदां बिखदां अशें दिवंक ना, टॅबलेट्स अशें कसलीच काय वखदां मेळोंक ना. फ्रेंड सर्कल सुद्दां मागीर तांकां बी कळ्ळें की हो आमच्या वांगडा काय येवचो ना म्हणून ते म्हाका मागीर आफोवपाचोच तेंच्यांनी बंद केलो. येताले बसताले पूण अशें सोऱ्या बद्दल काय उलयत ना. सांगपाची पद्दत आहा तेंचे कडेन. अशें जर प्रत्येक म्हाजें तरी बरें जालें, पण आनी कोण सोरो पिनारो आसा बरो, खूब सोरो पिता, तसल्यांक जर असले कावन्सिलर जर मेळत तर तेंचो बी सोरो.
So that's Manoj. He's one of the persons who received care from one of our lay health workers. And for me, personally, this endorsement from Manoj is bigger than any scientific publication that we have in any high-impact scientific journal. The reason being, it's the end user of our service who needs to find this useful. It's the end user who should be happy about what we are providing him or her. But finally, I would like to take a step back and try to think about what is the lesson that we can take from this, because this is just one story. What's the larger message that's coming out from this? And for me, the larger message is this. As a country and a society, we are at crossroads. We can choose to whine and complain about the fact that India is a low resource country. Alternatively, we could choose to look within ourselves as a community. We could choose to find solutions within our communities. And if we do that, I think we will find that we are a lot more resourced than we think we are. Thank you.